So good afternoon, ladies and gentlemen. My name is Eileen Regan. I'm the CCO of Examen, and it's my pleasure to welcome you all to our inaugural webinar series where we will be discussing male fertility. This is the first of our series, and the webinars are going to take place on a monthly basis, and we'll be joined each month by an expert in the field of fertility treatment or therapies. So the event's open to all. We have a wide range of participants joining us today, from healthcare professionals, reflexologists, nutritionists, as well as patients or individuals who are on their own fertility journey. So you're very welcome, and I hope you enjoy the event today. So I would like to introduce you to our speakers. First of all, our chair, Professor Sheena Lewis, who is the founder and CEO of Examen, an honorary professor in Queen's University Belfast, where for the past 25 years has dedicated her work and research on male infertility, specifically in sperm DNA quality. Professor Lewis is the past chair of the British Andrology Society, UK National Representative and past chair of the Andrology Special Interest Group of the European Society of Human Reproduction and Embryology, past executive member of the British Fertility Society, and a founder member and past vice chair of the Irish Fertility Society. She is currently an executive member of the Association of Reproductive and Clinical Scientists and chair of their advisory committee. She has published over 100 full papers and numerous book chapters and reviews. Professor Lewis's research led to the formation of the spin-out company Examen from Queen's University Belfast, marketing this exact range of male fertility tests powered by the Sperm Comet technology, which is the market leader for sperm DNA fragmentation testing in the UK and Ireland today. I'd also like then to introduce our speaker, Ms Srividya Seshadri, who has a dual accreditation in obstetrics and gynecology and subspecialization in reproductive medicine and surgery, and has been a consultant at CRGH since 2014. She's a consultant gynecologist and accredited subspecialist in reproductive medicine and surgery, and head of CRGH research and clinical development. Ms Seshadri completed her MD thesis on reproductive immunology at the University of Liverpool and obtained her master's in medical ultrasound from King's College London and specialising in 3D scanning. Dr. Seshadri's special interests include preconceptual care, reproductive endocrinology, reproductive immunology, recurrent implantation failure, and recurrent miscarriages. She has authored publications in leading medical journals and lectured on the above specialised areas of interest. So thank you to both Sheena and Vidya for joining us today. Before I hand over to our speakers, I just want to run through some housekeeping with you all as well. So we'll have about 15 minutes, 10 to 15 minutes from Professor Lewis introducing the day. Then we'll hand over to Dr. Seshadri, who is our resident speaker this month. And then finally, we'll wrap up with a question and answer with our speaker and Professor Lewis. So please feel free, ask questions throughout the talks. You'll have an option of a Q&A panel in your window, and you'll have the opportunity also to rate any questions that get added. And you can either ask the questions anonymously, or you can use your own credentials. We'll leave that completely up to yourselves. If you do experience any technical issues, please use the chat function, and we'll do our best to help you. Attendees will be muted throughout, and the videos are enabled for our speakers only. And our events are recorded and made available onto the events page following each of the sessions as well. 1 CPD point will be awarded for the 1 hour event, and certificates will be circulated within 24 hours of the event as well to you. And at the end of the session, you'll be invited to rate the event, so please do so, and we welcome your feedback on the event, as well as any suggestions that you have for future sessions. So without further ado, I will now hand over to our chair, Professor Lewis, to kick us off.
Good evening, everybody. I'm absolutely delighted to see so many enthusiasts who, instead of going home after a long day in the lab and have their evening meal and put their feet up, they are here listening tonight. I'm very glad it's not Sunday night, because you wouldn't have had me here. I'm too busy watching Line of Duty. But it's Tuesday night, and I'm very happy to be here and delighted to be talking to you all. And this evening we're going to be talking about paternal age. Now, I know this is something which is of interest to quite a few people, bearing in mind the number of people who want to participate. And it's something which has really come to the fore over maybe the last 5 years. But we'll talk about that in a moment, whenever I get this slide to work. Yes, here we go. First of all, I'd like to tell you a little bit about our business and why we actually want to talk about male infertility and to try and provide some education for those who want it. This is a spin-out company. It's come from the university. And of course, being an academic professor before I founded the company, my huge interest was in spreading the news about male fertility, to raise awareness, to provide men with knowledge and advanced testing. When we started to think about this 25 years ago, it was because semen analysis was such a blunt instrument, and still is. It's obviously the gold standard as the very first test that a man should have, but it's not the best test for many men. They need further testing. In our opinion, the inadequate testing led by just having a semen analysis has led to difficulties for many people. And as of course, many of you who are listening will know, about 25 to 30% of couples get a diagnosis of idiopathic or unexplained infertility. The man's semen is normal and the couple can't conceive, and there should be other tests, more detailed and more advanced tests, which will add to the semen analysis for these men in order to find out exactly what their problems are. We've been around for 10, 11 years now. We started out as a tiny little corner of a pathology lab in the university. And over the years, we have developed into a much bigger company. We've just doubled the size of our lab space here over the last couple of months. We have CE marks now. We had an ISO 9001, and we've just recently got an ISO 13485. So things are going very well. We have international customers as well as those in the UK. But as well as actually providing this commercial service, one of the things that we are very, very keen to do is to get involved in research and move the whole area of male fertility and our knowledge around it forward. And we have a very large research portfolio, which we pay for ourselves in order to try and increase the amount of research that's being done. And that's particularly important since Brexit and because of COVID, when there's so little funding around to do research. If we can aid some of our clients who are involved in research, and I have to say particularly CRGH, which is one of the clinics in the UK, which has always put research as one of its priorities, and we have been able to be collaborators with them on a number of occasions. The exact tests are based on all the research we've done over these years. This is all unpaid university research. We haven't had any funding for this except for the funding from research councils. So there's been no bias in what we've been doing. Why would you want to use us? Well, for the first reason I've told you, that we can diagnose male infertility more accurately than a semen analysis. We have thresholds looking at a whole group of fertile men. We have a fertile sperm bank, and so we know what fertile sperm look like, and we can compare those with every patient's sperm, and then we can predict the likelihood of IVF or ICSI being successful for them. I think we provide an excellent customer service. That's certainly what you tell us, and we have a great team here, and they're all very enthusiastic and very sympathetic to the many people who phone us on a daily basis. I'm sure some of you will know that there are a number of DNA tests around. The Comet test, or the Exact test, as we have branded it, is the only test that's on the market that actually quantifies the DNA damage per sperm and can tell you how many good sperm and how many badly DNA damaged sperm a man has in a particular sample. We can also detect single and double-stranded DNA breaks, which some of the other tests can't do. Over the last decade, we have got to a position where now about 80% of the UK clinics are using us in the private sector. And we're absolutely delighted about that, because we feel that we're able to add to what men have been offered in the past. The very good news from our point of view, and this is a platform I've been shouting on for about 20 years, is that DNA testing is something that every man ought to be have available to him. And now this is actually in 2 international guidelines. The European Association of Urology in 2020 has put it into their guidelines that semen analysis is not sufficient for people who have idiopathic infertility or for couples who have suffered recurrent pregnancy loss. And also in the ESHRE guidelines for recurrent pregnancy loss a few years ago, I had the privilege of co-authoring their guidelines. And again, best practice is to have a look in more detail at the man's sperm. And of course, this is something that's really moved things forward, because until 2012, we had no concept that recurrent pregnancy loss might be associated with men as well as their partners. So what does exact testing do for men? Well, it allows them to take back control. One of the things that we find is that men become disenfranchised. They feel embarrassed. We know that from if any of you who saw the Rod Gilbert documentary recently, but they feel that they're left out, they're discriminated against, in that the woman is the center focus in many fertility clinics, and the man is just on the periphery. He's just the partner of the woman. And so we have found that by talking to men about the quality of their DNA, about the quality of their sperm, it allows them to take control again, and allows them to feel engaged. And this is, of course, to the benefit of the man himself, but also to his partner. Tonight, we have the wonderful opportunity to hear Vidya talking to us, and she has been a collaborator with us from, I think, about 2016. We've done over 1,000 samples for the clinic, and it's increasing all the time. And it's a real privilege for us to have someone who has first-hand experience of Examen and our services to come along tonight and to want to be associated with us. I want to say something a teeny bit controversial. I know that Dr. Seshadri is going to talk about the facts and the scientific basis of paternal aging, but I just want to ask you a question. Here in front of you, you have quite a number of very well-known older men with their children. And everybody thinks that's absolutely fantastic. Well done, old chap. That's just great that you were able to father a child when you were elderly. And then in the middle, you have a woman who's called Bridget Nielsen, and she had the audacity to have a child when she was 54, and she got abuse from the media. They thought this was quite appalling, and she ought to have done it earlier, and she was a selfish woman, and she put her career before motherhood. And I'm just interested to hear what all the people who are on this webinar tonight think about this. There'll be a time in the question and answer time for you to tell us what you think. Is society just sexist, or is there a hidden factor that might mean that older men need something else in order to become fathers? In most of these men, I think there's something you might think about, and that is younger partners. If you have an older man and an older woman, would you have the same success? These men are all rich enough to have had a much younger partner in their lives. But as I say, over the last few years, we have had a bit of scientific information to suggest that sperm quality is decreasing as time goes on for men. I know we're going to be hearing a lot more about that later. And we'll find out if there is a health risk. Is there a health risk for the woman? Is there a health risk for the child? And if Dr. Seshadri convinces us that there is, then we'll have to ask, how can we change the status quo? What are we going to do? How are we going to influence society as professionals in this area? So what I'm going to do now is, I've talked long enough, I'm going to hand you over to the central player and the person that you've come here to listen to tonight, and that's certainly not me. You're very welcome this evening, Vidya, and we're delighted to hear what you have to say.
thank you very much, Sheena and Eileen, for an exemplary introduction, which I don't think is deserved by myself, but thank you very much. I would like to start actually by thanking Examen for inviting me for launching this well-needed webinar series for men, or focusing on men, can we say that? And I quite agree with yourself, Sheena. Are we living in a very sexist area? We've heard our patients tell us it all starts with the egg, but do we ever hear anybody say it starts with the sperm as well? Please don't leave the sperm behind. I noticed from our participants this evening, it's a very interesting mix. Some of my senior colleagues in the audience, so please do make it really interactive. I am going to make it a little bit controversial because it's nice for us to sort of see as if we can come to a consensus about when do we test, who do we test for, and what are the outcomes. So let's focus on paternal age and on fertility outcomes. And actually, we've published a few papers on this particular topic because we felt there was an increasing need to define paternal age. I'm sure you're all aware of the redefinition by the Americans for advanced maternal age of being above 35 years, but consistently in the literature, nobody has actually taken any interest in sort of making an emphasis on what is paternal age. That's a little bit about me, and I think Sheena and Eileen have introduced myself. I work at CRGH. But does paternal age matter? Because when I do speak with my colleagues, varied colleagues, you know, be it nutritionists, reflexologists, acupuncturists, urologists, and my colleague, IVF colleagues, they all have different views. Some of them absolutely believe that there is an effect of paternal age on sperm and reproduction. But some people actually have told me, actually, paternal age doesn't matter as long as the young woman is young enough. And I hope by tonight we change your opinion about the whole thing, because all I'm doing is presenting you all with the evidence. So yes, I know Sheena Lewis has sort of mentioned all of our male celebrities, and we look up to them and say, wow, you know, they're sort of trend setting in terms of defining, and there is nothing called as a male biological clock. Actually, the biological clock is reserved for us women only, and I beg to differ. So essentially, we all know the importance of a woman's age. The importance of the male partner's age is well understood. We all know sperm parameters alter with age. Some studies in the medical literature have suggested a negative effect, and some have shown no evidence of an effect. And I've just amalgamated that in our review paper, which I will present in a minute. So definition. As I've said, there is no consensus for the definition of advanced paternal age. Most professional societies, actually the American College of Medical Genetics has defined advanced paternal age as 40 years or older at the time of conception. And actually, based on this, the ASRM have said, okay, please establish age of 40 as the upper age limit for sperm donors. But there's been no similar movement in Europe or in UK to define the paternal age. So what about the context of age and fertility? This comes directly from the Office of National Statistics. And as you could see there, the dark blue line is all fathers. And this is the average age of men essentially over since 1938 to 2017, pretty much consistent. However, since 2000 actually, the number of men above the age of 40 entering into conception has increased. So what is this? And I know this slide is a little bit busy, but these are facts that we need to present to our partners, male partners of our couples. And actually, the most important question I get asked, does paternal age actually affect natural conception, or does in itself result in subfertility, or could it contribute to miscarriage? And actually, there was the largest survey that looked at actual natural conception, and I put the reference there for my colleagues to have a look. But they suggested that 76.8% of young men younger than 25 years impregnated their female partners within 6 months, compared to 53% of advanced paternal age men defined as older than 45. Now, this is natural conception. So we've seen already from this survey, the largest survey published, that actually there is a trend to decrease spontaneous conception rate. What about a prospective study that was subsequently published in the American Journal of Epidemiology suggested that actually partners of men older than 35 years were 1.26 times more likely to miscarry than partners of men younger than 35 years of age after controlling for maternal age. And this was actually the study that actually made us all sit up and think, yes, there is a male contribution to recurrent pregnancy or pregnancy loss rather than recurrent pregnancy loss. What about the systematic review and meta-analysis? Johnson et al., which is again a very good systematic review published in the Aging Journal, suggested that increasing paternal age was associated with a decline in sperm volume, sperm count, motility, percentage of morphologically normal sperm, and increased DNA fragmentation rates. I must admit, till 2 years ago, since our interest was in this realm, I never counsel the male partners of our couples, and should there be a shift or a little bit of a responsibility on our onus to actually educate and counsel our male partners. So I would like to, this is one of my favorite slides I'd like to show my couples, is because it talks about the paternal age effect on miscarriage rates. So I've shown already advanced paternal age increases or causes delay in conception, as well as, they would contribute to pregnancy loss. But let's look at this study, which is a beautiful study, which was published in Human Reproduction way back in 2002. And I would like you all to focus on the C graph that talks about maternal age between 35 to 44 years. And if you look at the paternal age on the x-axis, sorry, on the y-axis, and if you look at the 40 to 64 years, it places these women at a highest risk zone, which looks at the odds ratio of 5.65 times a miscarriage risk. And often it is very important to put this slide in the clinic when you're counseling patients with regards to miscarriage rates before you even embark on IVF success. Or it is very important to talk about this, because this gives you the exact odds ratios. So what about effect of paternal age on assisted reproduction? And over the last 10 to 15 years, there's been a plethora of papers. And this is one of the reviews that was published in Fertility and Sterility. But essentially, if you could see there, it highlighted the studies which showed that actually there is a decrease in live birth rate, at least in 2 papers, and 2 papers that were not very well robust in terms of their numbers, showed no significant difference. And let's look at effect of paternal age on reproductive outcomes like miscarriage and live birth rates. It actually shows us that, could you see there, the miscarriage rates increase. Quite a proportion of the smaller studies showed no significance, and the live birth rates, there is a decrease in them. Again, the large powered studies did show an effect of paternal age on the outcomes. In terms of the various papers coming through right from the beginning, from 2018, there's been a plethora of studies published in PubMed with regards to the effect. I think there was one question on the chat, which was very interesting. Do you look at sperm count only, or is that a marker for sperm quality? Should PGS be done? So in order for us to actually answer this question, we looked at our CRGH data. I've just heard this week that it's been accepted with minor revisions in a European journal. So essentially, we published this in 2019. Actually, we presented our data in 2019, and I'm sure you all have seen the ESHRE abstract, but just this is the largest study in Europe, 4,271 men. We looked at all cycles of IVF ICSI performed using freshly ejaculated sperm was included, and actually we excluded donor eggs. Sperm or surgically retrieved sperm were excluded. So donor sperm as well was excluded. And we grouped our ladies in these different age categories, and male partners were again grouped into the subsequent categories. And we used male age and female age of less than 35 years of age. We use as reference groups for comparison, like a self-controlled study. So essentially what we found was very interesting. If we look, this is generally, it just talks about the demographics, the number of cycles, the number of eggs collected. But very importantly, which is the question that everybody in the audience wants to know, could you see that this was our data, especially for men, when you compare it to 35, an ongoing clinical pregnancy rate. In our paper, we've got the live birth rate, which I can't share till it gets published. So essentially, if you could see there, actually subsequently above the age of 40, you do have this consistently decrease in ongoing pregnancy rates. And everybody who's listening in the audience would say, but hang on a moment, Vidya, but isn't this actually wrong? Because you don't know how many of these men have had older women, i.e. above the age of 35, we controlled. So all of those men in the previous slide, actually, we divided into women less than 35 years of age. So men in those categories who had treatment with women less than 35 years of age to standardize the variable. And essentially what we found, of course, from our data, maternal age and predicted probability, clinical pregnancy, all of us know that, decrease in success rates. But look at the paternal age and predicted probability. Could we see that above the age of 40, there's a gradual decline in the prediction probability of ongoing clinical pregnancy rate? And essentially, what about miscarriage? Because miscarriage is another very important outcome of ART cycles, and we can see maternal age on the left is well published and well known, but look at the paternal age. What we did find that especially in men above the age of 46, there is an increase in the miscarriage rate. Now, what is causing the shift? So I'm sure that I've convinced at least everybody in the audience that there is some sort of effect of paternal age. Yes, we are all unaware what is the age. Should we just go with about 40, like the Association of Genetics have suggested, or should we move it to 45? Or on this side of the continent, are we different? But I've just shown you from our study based in UK, which is the largest in Europe, it has suggested this drop in ongoing pregnancy rate and increase in miscarriage rate. So we sat down and thought about it, and could it be because of the effect of sperm DNA fragmentation? And we all know, and I know Professor Sheena Lewis has published a lot of papers elucidating the role of DNA fragmentation in the outcome. And yes, through the deterioration of sperm DNA fragmentation of quality, we could assume that there is a link between advanced aging and an increase in sperm DNA fragmentation. Now, everybody, I know there is always a controversy when I say this, because everybody says you can't really connect the two. It's like this. Advanced maternal age, we all know that there is this process of apoptosis and programmed cell death. So should this be actually, and there has been scientific models showing actually elevated sperm DNA fragmentation with age, and why is it that we're a little bit reluctant in accepting this for men? So let's look at ART outcomes and also our data. We amalgamated globally in the medical literature. What are the papers saying and what should we define as the age? So we asked this question: does increased paternal age have an independent effect on live birth rate, clinical pregnancy rates, or miscarriage rates? And we included, again, all cycles in the medical literature that resulted in a fresh embryo transfer assessing the impact of paternal age. And what we found was very interesting. In autologous eggs, essentially, if you look at paternal age less than 40, if you could see that, versus more than 40, there is definitely an effect of paternal age. Let's look at it in the donor model. And in the donor model, what you find is there is no significant difference in terms of the ongoing pregnancy rate. What about the clinical pregnancy rate? Again, paternal age less than 40, could you see consistently higher in men less than 40 years? Again, in the donor, could you see that actually success rates for paternal age is slightly, it's not statistically significant, but slightly higher in the donor egg model. And the only way we can explain this, which I will come to in a minute, but if you could look at this slide, which talks a miscarriage rate, again, paternal age clearly sort of drawing the effect towards miscarriage rate. And looking at donor, especially for men more than 50 years of age, because everybody listening in could say 40 is too young, maybe we should move it to 50. We did not find actually an improvement or anything in the live birth rate, so essentially no difference in men less than 50 versus more than 50. But essentially what we did find is a miscarriage rate is consistently, it's a trend, but not statistically significant, especially in men above the age of 50. And this is in a donor model, so therefore this is more. Now, if you look at the numbers, apart from the 2014 study, the rest of the studies were very small. So even though there is a trend towards higher miscarriage rate in men above the age of 50 years, we need to do larger studies to confirm this finding. Now, what is my concern about advanced paternal age? One is the association of advanced paternal age and genetic risks, de novo autosomal dominant mutations. And it was very surprising. If you look at this paper that comes out from 2012, actually this pair have described a class of syndromes caused by new dominant heterozygous mutations, and they called as paternal age derived disorders, which is actually worrying because actually it shows a strong paternal age effect and a high germline mutation rate. What is the other risks? There are a higher risk actually of X-linked disease, but not autosomal aneuploidies. We know that trisomy 21, 18, 13 do not increase with paternal age, but it increases with maternal age. But however, X-linked disease is associated with advanced paternal age. There is evidence that offspring of women who are born to older fathers have an increased risk of X-linked disorders. Very important. What about copy number variants? All pregnancies are at risk for copy number variants, regardless of maternal or paternal age. So we can actually reassure our couples that X-linked disease slightly higher, and these de novo new advanced paternal age mutations we need to warn our couples for. So these are, I've just picked this up from the paper that I've alluded to earlier in 2012. These are the syndromes that are connected with advanced paternal age. And I'm sure we've all come across, I know these are some of them rare, but we've all come across achondroplasia and Noonan syndrome. Again, very important for us to counsel our patients, especially in men above the age of 45. What are the other adverse reproductive outcomes? We didn't know till we looked at the medical literature that there are associations between advanced paternal age and various childhood cancers like leukemia, non-Hodgkin's lymphoma, pediatric central nervous system tumors, and breast cancer. The hypothesis is thought to be due to telomere shortening. And I'm sure you've all heard this. Telomere shortening is thought to be associated. There are some papers that suggest that DNA fragmentation elevation can cause telomere shortening and therefore an effect of the sperm on the offspring. Frightening. And also congenital anomalies like cleft lip, diaphragmatic hernia. There is a contribution of paternal age. When you look at the medical literature, these are the odds ratios we need to counsel our patients. Psychological disease and neurodevelopmental outcomes. There is an association between schizophrenia. A recent paper over the last couple of years have shown this association exists. So essentially, let's look at the studies. So yes, we know from our in-house study, 40 years and above, there is that increased risk of miscarriage and decreased rate of ongoing clinical pregnancy rate. So what do? Sperm DNA fragmentation. And I know there will be participants listening there saying, oh gosh, what do we do with the sperm DNA fragmentation? Because it's a test that nobody knows what we need to do. And everybody is right. When natural killer cell testing came, this was a couple of decades ago, there was a fury. There was a debate on whether it's good, it's not good, but some said it's good, but nobody knew what to do with it. Should we standardize the test? But here we've got a test that Sheena has got it CE-marked and essentially established, which is guiding us to the levels of DNA fragmentation so you can advise the couple or the man what he needs to do to improve that fragmentation scores and improve the outcome, then why not? So essentially, male age, if you're using donor eggs, even above the age of 50, there is no negative effect on the ART cycles. Why? Because we all know that younger the egg is, it does tend to do a little bit of mitochondrial repair, as well as it tends to compensate for the paternal age derived genetic links or association with miscarriages. But if it is autologous eggs, yes, we've shown that the meta-analysis shows that male age over 40 years reduces the chance of clinical pregnancy and live birth rate. I do feel couples with advanced paternal age, so men more than 40 years, should be appropriately counseled about the reproductive risks. And we don't do that because we focus completely on the women. And there should be more studies evaluating sperm DNA fragmentation in men over 40 years and the various outcomes. In fact, we're just going to launch a prospective study. We still are in the process of doing that with Sheena and ourselves, where we're going to look at men above the age of 40 with their outcomes and have a control group. So yes, we need more studies, but actually there should be a little bit more thought to the workup of the male partner in a couple rather than just completely ignoring them. And I think it's time has come for the ART world to sit up and just take notice of their male partners, of their couples. But that takes me to the end of the talk, and I'm sure I've said something really controversial along the way, which I am actually very happy for all of us to discuss, because that's why we're here today. And I will be guided by actually Sheena, who is a leader who's published a lot of papers and evidence in this realm. But I do invite some people, members of the audience as well, to ask us questions.
Thank you very much. That was really very, very interesting. And I'm delighted to hear you saying that the donor eggs don't really have any effect, that they can compensate for the older sperm. And this is, of course, exactly my theory. that if you have donor eggs, and this is exactly why celebrity men, they've got either younger partners or even celebrity women using donor eggs, and it's giving the impression that, you know, these much older women can get pregnant in their 40s and 50s, but it actually isn't the real truth, and I think it deceives a lot of people. So I'm glad to hear you say that. I think we have one question here. What's the difference between a Scasa test and a Comet test? And in what circumstances would you choose one over the other? Well, I would love to answer that one because it's something that I've written about on many occasions. The difference is that the Scasa test looks at the whole semen sample and gives you one result. And say the result were 30%. What it does is it looks at 100 sperm and it finds damage in 30% of them, and it doesn't find any damage in the other 70%. So it gives you a result of 30%. Our test is totally different. We look at the amount of damage in every single sperm. And because our test is so sensitive, we can find damage even in fertile men's sperm. So we work on quantitative analysis. So we say we've got a threshold, say 25% is what a fertile man's sperm might look like. But if you look at a patient, then we can give you 3 results. We can say, here's the average amount of damage per sperm. Here are the number of sperm, the proportion of sperm that have very low damage and look like fertile man's sperm. And here are the number of sperm that have really bad damage. And all of those can be taken into consideration by the clinician and the whole healthcare team to guide the couple in whether they ought to have IVF or ICSI, or in directing them to interventions. Perhaps they've got a varicocele, and we know that the repair of a varicocele can lead to a reduction in DNA damage within 3 to 6 months. So that's something very important, and this is the reason why I'm always saying that it's really a good idea, as CRGH has, to have urologists on their teams who can look at difficult cases that men are finding very difficult to have success, and just look at their general health and also clinical examinations. And I think that's something which really isn't done very often. Am I right, Vidya? Are you pretty unusual in that respect?
Absolutely, absolutely, because we do have, which I will tie in with one of the questions I think the audience has asked. But before I just go about that, there is a question that came on quite early on, which is very interesting, Sheena. And one is, there are 2 parts of the questions. Is PGS recommended more for couples who have severe male factor infertility, or is it the case that low sperm count does not necessarily equate to poor quality? Very interestingly, please remember, PGS recommendations, I mean, you would have to look at the female age of the couple, but one of the indications for genetic testing, as the ASRM have said, is severe male factor. So it's not necessarily if they do have male factor infertility, they must have PGS, because if the female age is young, you really don't need PGS for severe male factor. The second part of the question is, we were just talking, Sheena and myself, about the low sperm count does not necessarily equate to poor quality. There's a beautiful study published by S. Steves et al. In 2015. And what they did was they looked at men less than 2.5 million per mil of sperm count, which is what your question is alluding to, and they did the DNA fragmentation score. And then they divided how they're going to extract the sperm. So these were men less than 2.5 million per milliliter, high DNA fragmentation. One group had teaser on the day of egg collection and sperm derived surgically versus ejaculated sperm. And they found that the ongoing pregnancy rates were higher in the teaser derived sperm for low sperm count with a high DNA fragmentation. So I hope that answers that question. I think there is a shift for men with a low sperm count with a high DNA fragmentation, a little bit of thought process to the type of sperm used for insemination and the method of insemination. Please do correct me, Sheena, if I'm wrong about that.
No, that is correct. Absolutely.
And there is on the chat, Sheena, there was a question. One is for yourself, do we know what percentage of men with no fertility issues will have an abnormal Comet test? And I'll take my question later.
Yeah. I'm not sure what you mean, the percentage of men with no fertility issues. What I can certainly tell you is in our fertile group of men, they all had DNA damage, but it was below our threshold. So they would have had, about 15% damage. So all men have a little bit of damage in their sperm, and that's because sperm don't have any repair mechanisms. So smoking or living in London and pollution and all the things that happen to us in our everyday life will create damage in men's sperm. If you're asking me about the percentage of men who have no fertility issues in the sense that they have a normal semen analysis, but they're actually attending for investigations, yes, about 40% of men who have normal semen have abnormal comets, have abnormal DNA. So that's another, 40% of those men can be given a diagnosis. Yes, there is something wrong with your sperm. That's one of the reasons why you're not able to conceive. And certainly investigations and interventions will help you, as I was saying, perhaps a varicocele repair, or perhaps changes in lifestyle, or perhaps stopping smoking or losing weight, or various things that or being given vitamins or antioxidants, things like that can help. Lydia, you have a question.
And, the question for me was, what advice do we give to reduce the DNA fragmentation to the men? So lifestyle advice. And if you would read Infertility last year, we published the preconceptual advice we give for men, especially advanced paternal age and raised DNA fragmentation. So the regular ejaculates, antioxidants, the selenium, zinc. I know that there are companies that look at, developing these antioxidants. There were a few supplements on the market that they've taken off. But essentially, the main question is, should we delay ART for how long? Now, we don't tell them to delay it, because if the female age is quite high or their egg reserve, so those are the drivers. And essentially, if we've got raised DNA fragmentation, if you all have looked at what Examen report produces, they produce an IVF column, whether that particular man's fragmentation is raised compared to the IVF score or an ICSI score. So essentially, it will help derive the type of insemination rather than delaying ART, because we all know it's a 3-month cycle for production of sperm. We can't tell these men, go away for 3 months, we're not going to see you till. But please do tell me otherwise, Sheena, if that's right. I know you recommend repeating the DNA score.
Yes, we do, but I fully understand, and particularly with the pandemic, that people are very hesitant to delay if they have an opportunity to have treatment. I suppose I would suggest if people have failed treatment, then they might want to consider improving their sperm quality if possible before their next cycle. But that would be with a younger woman. If you have a woman who's 39 or 40, I totally agree with you that delaying their next cycle of treatment is going to be disadvantageous to them, because the female age is one of the most important factors in terms of success.
Absolutely. There's a question, Sheena, I think we can possibly both attempt to answer it together. If you have advanced paternal age and high DNA fragmentation, what are the likely causes, and what are the recommendations to help identify the causes and advise or treatments to reduce this damage? Good question.
Yes, absolutely. There 2 new papers came out last year. One was a study of 6,000 men, was an Indian study, and one was a study of 16,000 men. It was an American study. And the Indian study showed that as men got older, over 45, their DNA damage increased very significantly. The American study was even worse, and it showed that they had these 16,000 men, they had them in different age groups, 30 to 35, 36 to 40, 5-year increments all the way up to 55. And they found that over 35, there was a significant increase in DNA damage. So yes, there is a relationship between men getting older and DNA fragmentation. We've established that. What are the likely causes? Well, the problem is that the 21st world is an awful place for sperm. There just seem to be so many hazards around for us, not only in our diets, but in our weight, in our inactive lifestyles, in the fact that we smoke. And even if we don't smoke, we're exposed to all sorts of toxins and pollutants in our everyday life. So I think many of those, a lot of them beyond our control, are, and of course, the older a man gets, the more opportunity all these pollutants have had to damage his sperm. Now, I know we create new sperm every 3 months, but those sperm are all created from sperm stem cells. And of course, as the men get older and older, the number of times that those multiply and produce sperm, it gives more and more opportunities for the multiplication to go wrong and the actual generation of new sperm to go wrong. So I think those are some of the reasons. How do we identify the causes? Well, DNA quality seems to be one of the central things, because that's what makes a child look and act like their father, is the DNA. It's not how many sperm you have, what the motility is like, what the morphology is like. It's the actual genes that the father gives to his child. So that's one of the most important things I think that couples can look at. And in terms of how you reduce the damage, I think we've probably already answered that. Vidya, what would you say to someone who came into your clinic?
So essentially, another point about the causes would be things like varicocele, because often men do hide unless they're asked, they don't reveal these additional. So sometimes if they do have noted a varicocele or epididymitis, sorry, I've got this tongue tie, I can't pronounce that, but prostatitis, epididymitis, any inflammation that needs to be ruled out. And quite often, if you delve into the male history, they do give a history of recurrent UTIs, and they all can be linked to having high DNA fragmentation. And again, as I said, advise at the moment, we only have lifestyle. It's like when you've got a lady with advanced maternal age with low egg reserve. Yes, you can offer DHEA, bit controversial there as well. But theoretically, advanced paternal age is only lifestyle changes and antioxidants. That's the best we're going to get. Are we going to get to a stage where we're going to be able to identify the sperm on the day of the ejaculate for insemination? That is something, Sheena,
yes.
If you do develop something like that, let us know, because that's the question patients ask us, is could we identify the sperm with a low DNA fragmentation for insemination? That would be perfect.
Yes, I totally agree. And that is a very important factor, because although at the moment we can give you the diagnosis and say, yes, one of the problems is DNA damage, we cannot provide a way, apart from just the way sperm are prepared at the moment by density centrifugation. And I know there are all sorts of things like microfluidics, which may be coming on the market, and there are other different types of sperm preparations. Within the next 5 years, we may very well find that those are actually commercially available, and that will be a game changer. In terms of what we can do to reduce DNA damage, well, one of the things we can do, not for the people who are listening tonight, but for your children, is we can start educating boys as well as girls about their fertility. We can start telling fellows whenever they're in school, you've got to build fatherhood into your 10-year plan, not just your career, not just buying a new home and a new car and more holidays. Just like a woman, you've got a biological clock, and if you want a family, you've got to think about when you're going to put that into your life plan. And don't wait until you're 45, because there's only a limited amount we can do at that stage, but we can help the next generation if in society we put the right education in place.
Yeah. So, and the question goes on, should we be the next step nutrition changes? And I know there are a lot of skeptics out there about why is nutrition going to change. I would like you to actually look at a paper called the Earth Study, and I'm sure, Sheena, you would have read that. It came from the Dutch. And essentially, they did suggest when they look at men and women preconceptually, they give them 3 months' time and they give them intense nutrition advice. Mm-hmm. And we all know that epigenetics do exist. That's the expression of our DNA in relationship to what we eat, So yes, absolutely, nutrition is very important, and this is where, you know, supplements and antioxidants and what you eat, the diet for men is very, very particularly important. One last question on the chat, which is there, I think somebody has asked them, which is another controversial question: is there a link between autism and advanced paternal age? As far as I'm aware of the etiopathology of autism, it's a multifactorial condition. You don't know whether intrapartum hypoxia causes autism. Is it the mother's age that linked, or is there sporadic mutations causing autism? So there's no clear link between advanced paternal age and autism as yet. There's no clear link. There might be a contribution factor, but it's not a specific cause and effect.
Okay, and I'm allowed to answer one last question, and that is, does the exact test differentiate the percentage of single and double strand breaks, or just give scores? It doesn't separate them, it measures them both. We are at the moment doing a very big study to look at double strand breaks, separating them out so that we can give another test. And that will be available probably in about a year's time, because we're doing it. We've got a lot of information. It looks very exciting. It may be that double strands are more important than single strands, because the egg may have more difficulty in repairing those post-fertilization. But you'll just have to wait a little bit longer until I give you the definitive answer to that. Thank you.
So thank you, Sheena. Thank you, Vidya, very much for your questions and for a very lively discussion. And also thank you everyone for joining us this evening and taking time out of your day, and especially probably at your dinner time for many of you to join us for the events. So just before we wrap up, I just wanted to remind you of the events that we have coming up. So on Thursday, the May 25th, we're joined by Melanie Brown for Melanie Brown Nutrition, where she will be asking the question, can diet and lifestyle improve male fertility? And then we're very honoured to be joined by the Distinguished Laureate Professor of Biological Sciences from the University of Newcastle, New South Wales, Professor John Aitken, on July 6th. That will be an early one at 10 a.m. to allow for the time difference between here and Australia. So we'll be discussing his latest breakthrough paper and asking, should we be measuring DNA damage in human spermatozoa? So if you haven't registered already for the events, you can do so via our events page on your website, on our website at examenlab.com/events. But that leaves me just to say thank you very much again, all of you, for joining. You will be asked to rate and provide some feedback at the end of the event. We'd really appreciate it if you could do that and see if there's things we can improve. It's very welcome. And our contact details are provided on screen. So please do get in touch if you want to find out more about Examen or our tests. And if you have any questions that we maybe didn't get time to answer, we'd be happy to follow up as well. And we look forward to seeing you at the next webinar on May 25th. So thank you again. Thank you to our speakers. Thank you to our chair, and enjoy the rest of your evening, everyone.